into anatomy that's thick enough that you might consider using a grid. You can shoot them tabletop. If you shoot them tabletop, you might want to use a grid. You can shoot them upright. I'll go ahead and say that any kind of shoulder pain, be it humerus, proximal humerus, all the way up through clavicle, there's positional pain. So my recommendation of patient care, general patient care for the patient, is try to shoot them in some form of position that they're in. In other words, if they come to you on a back, not on a backboard, but on a stretcher and they're already laying down, scoot them over onto the table and shoot them with them supine. If though they're able to stand and participate or sit on a stool and they come to you in a wheelchair, I recommend that you leave them upright. If you have to take them from upright to supine or supine to upright, then I really recommend that you put them on a stretcher and have that as support of the stretcher to lay them down and set them up. It makes it much more comfortable for them. I've had shoulder injuries, and I can tell you going from here to here to here is painful without a lot of support. So keep that in mind. But if you do choose to do tabletop, you might want to consider using a grid. If your machinery uses a virtual grid, that's probably going to be adequate for a shoulder. Most of patients, shoulder issues not going to be thick enough that virtual grid wouldn't be sufficient. So for the humerus, though, you might want to consider using the anode heel effect. So if you have a patient with suspected fractures, you know not to move them. You know that our routine for shoulder is internal external rotation. So if a patient has a fracture, and most of your humerus fractures are going to occur in your older patients, so they fall down, they try to catch themselves, and in a lot of cases they wind up with two fractures. One, a Colles fracture, because they tried to catch themselves and they got forward momentum, and as they land, that distal fragment pops and you've got that, wrist fracture. Another thing is a compressed fracture of the proximal portion of the humerus. So we've got a little bit of telescoping of the humeral neck up into the head of the humerus. So you may, though, have some midshaft fractures. You may have some spiral fractures and things like that. And if you've got that going on, whenever you go to internally, externally rotate, you're going to have, first off, a lot of pain with the patient. And secondly, you're not going to have true rotation of the proximal end. Some of that rotation is going to take place at the fracture, and that's going to hurt the patient. So if you have any idea that the patient has a fracture, then I'd recommend that whatever position the patient's in when they come to you, shoot kind of like a scout image. So if the patient's holding their arm, really favoring their arm, go ahead and shoot it just as it is. Take a look, see if there's any kind of fracture there, and if so, then that becomes your AP. Now you got to worry about getting another view 90 degrees from that. So how you get to that, we'll get to here in a minute. But if the patient can internally, externally rotate, then that's your routine for the most part. The difficulty with humerus is that with the humerus, we're going to have a tendency to want a phototime, and our phototimers are going to be larger than our humerus. So you know enough about phototimers. Phototimers are going to be a little bit smaller than this. Okay, so just review. How do phototimers work? What's that?
The radiation hits the phototimer, and then it terminates the exposure at a certain.
Right. It just counts photons. It terminates the exposure whenever it gets to the proper exposure. Just sends a signal over to the timer circuit to kill the exposure. Right. So how big is your humerus compared to your phototimer? No, there you go, not as big, right? So compound that with the fact that you've got to abduct the humerus, get it out of the way, right? Otherwise you're going to have soft tissue of the upper thorax on it, and possibly even the ribs. So you got to abduct it a little bit. Now, not only do you have a smaller anatomy than your phototimer, but also your anatomy is going across your phototimer at a funny angle, and it becomes difficult to put it in the center of the phototimer, okay? So if you can develop, in your mind a set of techniques for a humerus or anatomy the size of a humerus, I really recommend turning the phototimers off and just shooting, with a set technique. It's more difficult to phototime a humerus than what it seems like it should be. If you can't do that, then what I recommend that you do is use those density controls on your control panel. Hit it with +1, +2 even, in order to compensate for, any kind of positioning variance that is not 100% accurate. All right, so internal, external rotation, and this, we're kind of covering humerus and shoulder all at the same time, but what we're looking for on internal, external rotation is where are our tubercles, and all you have to do is follow your thumb, right? So on external rotation, what you get is, the hands supinated, the patient's kind of in anatomical position. With external rotation, what we're going to have is our greater tubercle is going to be projected outward laterally. Okay, follow your thumb. It's going to be outward laterally. On internal rotation, our lesser tubercle is going to be medial on both the humerus and the AP of the shoulder. Okay, so once we get in the shoulder, you see in the textbook neutral rotation. And with neutral rotation, you got the patient's got their hand just on their thigh, and you don't see either one. You don't see greater tubercle, you don't see lesser tubercle, either one. So those are your three projections of the shoulder, provided the patient doesn't have a fracture. So what if the patient does have a fracture? Well, then we've got to do some other stuff. Again, you shoot your first one with the patient, just as they present to you, and then you've got to get something 90 degrees from that. So you've got options. The first option is to get a distal, get a lateral for the distal, and whether or not it's truly lateral is irrelevant. If the patient's hand's going across their chest like this, it's really closer to internal rotation, right? So it's not truly a lateral, but all we're trying to accomplish is 90 degrees from the previous image. So what you're going to do is you're going to take your image receptor and put it up under the patient's arm as far as it will go and shoot the distal portion, right? You're not going to get the proximal portion because, I always do that. I sat there and I thought femoral, and then I talked myself into, I thought humeral, then I talked myself into femoral. And it was humeral. Anyway, changed my answer on test. So anyway, put the image receptor up under the patient's arm as far as it'll go and get the distal portion. Moving the arm as little as possible, right? So the patient came in, they're here. You shoot your AP. You shoot your distal, right? And then you still have options for the proximal end. I'm going to talk about the one that I don't like, but a lot of people do. And then I'm going to talk about the one that I do like. So first off, let's say on this patient we're interested in the left humerus. So they've got a potential fracture. Whatever position the patient was in for the AP, they need to be in the same position for the lateral. And what I mean by that is this. Some of your patients are tough. You get you a little old lady, has had multiple childbirth, she can put up with a lot of stuff, right? So she may come in holding her arm and, you ask her, can you do this? And she'll do that, even though she's got a fracture, right? So whatever position the arm is in for the AP, it needs to be in the same position for a transthoracic lateral, okay? Because think of this, all right, so what do we see on external rotation? Greater tubercle on the outside, right? Internal rotation is going to be less tubercle on the inside. Okay? So if I've got if I've got the patient in external rotation and if their proximal humerus rotated, then my greater tubercle is going to be pointing out that way. Right? So I've got the patient in this position, and because now you made your exposure and the image comes up and you see a mid-shaft spiral fracture on this patient, what's your first thought? From a patient care standpoint and an empathetic standpoint, what are you going to tell the patient?
To relax.
Relax. And so what are they going to do? They're going to drop it and they're going to grab it like that. Now, if it rotated, now where is your greater tubercle? It was here, and now it's here. Right? So now you turn to shoot a lateral, transthoracic lateral, and what are you getting, really? Same image of the proximal portion of the humerus, right? So if you did this, and you got that patient into this position for the AP, they need to be in that same position for the lateral. Otherwise, you get two different looks at the same anatomy. Okay, so let's assume that you didn't do that. Let's assume that you shot the AP, you saw the patient had a fracture, you did the lateral with the image receptor up under the arm, and that would be with the image receptor towards the x-ray beam. Now you've got to get a proximal shoulder humerus. So what you're going to do now is you're going to put the side of interest closest to the image receptor, you're going to elevate the unaffected side, and you're going to shoot transthoracic. And the only thing that you need is a proximal third. You don't need the entire humerus. So to increase the visibility, of course, we're going to use a breathing technique, so a minimum of 1 second exposure depending on how still your patient can be. If your patient can be still enough, a 3 second exposure is even better. A 1 second exposure, probably the best you're going to be able to do is watch the patient, rotor up and watch the patient, and make an exposure at the end of inhalation, right? And that should be enough to move the ribs and the lung markings enough that you can better see the humerus. But if the patient can really be still, I recommend 2 to 3 second exposure to really blur all that stuff out. Okay? And what you're going to wind up with there is the humerus still with lung blurred out, but still with lung markings and with ribs all over it. So it's still going to be an ugly image. So what I recommend and what I always preferred to shoot if this was the case is a Y view. Okay? So Y view they can be a little bit challenging, especially if the patient's on the bed. It really becomes a challenge to rotate the patient up adequately to get a good Y view. So the degree of rotation is going to be dependent on the patient's body build. Some patients you're going to need to rotate about 45 degrees, some patients closer to 60. So what the textbook tells you to do is to find the vertebral border, which is that thin portion, and the axillary border, and feel of both with your fingers. And then rotate the patient until your fingers would be superimposed on the shadow and make your exposure that way. You can shoot these AP or PA, doesn't really matter which way you go with them. I'm doing this because this is what I'm most comfortable with. I think most people shoot them AP. I always shot mine PA because I just didn't like the look of the AP with magnification. Especially on films, when we used films, it would take up an entire 10 by 12 film. I just didn't like that, so I always shot mine PA. But I think I was an outlier. Most people shoot them AP. So the problem with this is that we live in East Texas, and we have a little extra fluff on us, a lot of us do, me included. That's going to be hard to find, right? It's going to be hard to get your fingers on that unless your patient is small enough that you can actually feel it. Also, if the patient has any damage to the scapula, that's going to be probably prohibitive of you to do that. So what I always did was I'd take my hand and I'd put it directly on the scapula. And, notice on the scapula you've got this ridge, so you've got muscular tissue and adipose in that area right there. So what I would do is I'd take my hand and I'd put it on the scapula, and I'd put my hand until it's turn my hand until it's perpendicular to the image receptor. But because of this area right here, doing so would not put the scapula perpendicular to the image receptor. So what you would need to do then is put your hand on the scapula and then rotate the patient just about 5 degrees more in order to get the scapula perpendicular. Your hand's not perpendicular, the scapula, your hand is perpendicular, the scapula is not perpendicular, so you're gonna have to rotate the patient just a little bit. So, and by a little bit, I'm talking about like 5 degrees. It's very minimal, and that was always successful for me. So the reason that I would shoot my proximal in a Y view is because you have less tissue on top of it. The only thing that's going to be on top of it is going to be the scapula, which in comparison to the humerus is going to be a small bone. You should be able to visualize the humerus on both sides of the scapula if positioned properly. It's just a better image in my opinion, so I always preferred that. If you have, the freedom to choose, choose whichever works best for you. That was always my preference. All right, so fractures, we can have a lot of different types of fractures. I'm going to enlarge this. Yep, I got to enlarge that before. So, So we've got a nasty fracture here. The problem with your true long bone fractures is that they can break off. They can have we can have a spiral fracture that could potentially cause other issues. These sometimes we'll refer to them as bayonet fractures. Bayonet being a big knife you stick on the end of a rifle, and that can do some damage to artery, nerve, vein, anything like that. So you got to be really careful with it. So I think this patient was probably just slung for the moment. This is kind of rare. This looks like a pediatric patient who's got a transverse fracture that I've just never seen. Looks like it's still got open growth points. So, proximal, mid-shaft, distal fractures could be just pretty much anywhere. So, again, this kind of demonstrates what I was talking about before. What do you see right here? What is that little round thing right there representative of? Your photocell. Right. So you make that exposure and that photocell sticking out there like that. What's that photocell getting? Direct radiation. So what's going to happen to your exposure? Yeah, it's going to stop real quick. So it's tough to cover that whole thing up, with the patient's anatomy. So again, set your technique if at all possible. If you can't set a technique, if you don't know a technique, go ahead and use, I'd say, +2. All right, so this is what we're looking for. We got the greater tubercle on the external rotation. PD humerus, kids just aren't human. They lack a lot of bones. So, anybody shot a hand on a, say, 1-year-old? It's shocking how many bones they don't have in their hands and their wrists, especially the wrists. They're just gone. They're not formed yet. All right, so any questions on humerus? So on your lateral, external rotation, internal rotation, on your lateral, you can do that in a lot of different ways. what you see sometimes is the technologists have the patient, providing they can perform it, and they don't have a fracture, put their hand on their hip. That's great. It accomplishes everything. It puts the condyles pretty close to perpendicular to the image receptor, internally rotates. All of that works, right? You can also, you know, if the patient just has to hang on, they need that support, you can turn the patient around and shoot them in a PA projection, or in what we, you know, the upright equivalent to a prone position. If you shoot your internal rotation with the hand across the chest or the stomach like that, what you're going to have is you're going to have increased NOID on the distal end. You're going to have foreshortening, you're going to have distortion and all that. So much better idea if the patient just cannot, you know, put their hand on their hip or whatever, you can just turn them around and shoot a PA. It's a good tip. Things to look out for: soft tissue overlap. You know, part of that's going to be patient body habits, part of it's going to be patient positioning, part of it's going to be gender. So you got to watch out for that. Kind of beating a dead horse here. Transthoracic. That's some pretty good transthoracic. It still looks, you know, kind of messy.